I'm Claude Laberge. I used to be the scientific director of the project Cartagene. Philip is now the director of Cartagene.
Yeah, I'm Philip Awadala. I'm at the University of Montreal, and Cartagene is the University of Montreal project. I'm a faculty there and the Faculty of Medicine.
The project has completed a biobank on 20,000 Quebecers chosen at random by the Health Insurance Board between 40 and 69 to represent the population of Quebec from Montreal, Quebec City, Sherbrooke, and Chicoutimi. So this was completed a year ago, in November 2010, and it's a resource available for researchers either in Quebec, Canada, or internationally. So it represents, the aging population, and we have data on their history, their medical history, their socioeconomic status. We have DNA, we have biologicals, and about 25% of French-Canadian extraction have genealogical information also. And Philip is now in charge, so he'll tell you what we can do with it.
So it effectively is the Quebec Health Survey. So we can follow participants over time as well. And the real power and the real value of a project like Cartagene is it's not just a biobank with one time point where we have a snapshot at this time. We have actually the ability to go back over time, recon participants, see who develops what type of, say, chronic condition or disorder, and identify maybe a biomarker or a genetic factor that could lead to a predisposition or be an indicator of a predisposition for a genetic disease. And so that's some of the research that's currently ongoing with Cartagene, not just by us, but also research scientists in the province as well.
We have the consent for 50 years, so people can be recontacted, or we can follow them through the administrative data bank from the Health Insurance Board, the hospital boards, and so on. So we can see what kind of evolution they have. We probably 20% have no problem at the moment, but eventually they'll get some. So what are the pathways by which they're going to express this? So in terms, it's a resource that can be useful for public health prevention, but also for orientation of personalized medicine eventually, because they represent the population.
So an excellent example is the rise in obesity rates. Obesity has probably gone from, say, 15% to 25% over the past, say, 15 years. If we can determine, using, say, genetic tools or genetic bioenvironment tools, what are the main factors associated with that rise, we can implement strategies both at the public level or the federal level or the provincial level to try to minimize that and, of course, reduce the burden on the taxpayer in the long run.
We've got some preliminary data that Philip did. Maybe you can, for example, the hypertension rate is high. So if it's high at 40 to 55, probably that's nascent or there before. So that's an example.
And from a genetic perspective, we can determine what are the biomolecular factors that best explains most of that variation. For example, for, say, BMI or cholesterol levels, from a genomics perspective, we can use or determine that it's not just which genes you have, but how those genes are turned on, and they can explain up to, say, 25% of the variation in the population, for example, for, say, cholesterol levels. And that's a very powerful tool. In the past, we haven't been able to explain that much variation. And when you have a cohort like Cartagene, you not only have deep measurements from every individual, you have a lot of measurements from a lot of individuals as well. And that's why we can get those statistics.
That just kind of looks at